So good afternoon, everybody, and welcome to Sunrise over the Trackers Island, the top 5 advancements in glaucoma over the past decade. I would request my co-instructors to please come on to the stage. Dr. Devendra Sood, Dr. Kirti Singh, Dr. Susan Jacob unfortunately is not here. In place of her is Dr. Sumathi. Dr. Jacob is actually suddenly caught up in a medical emergency at home. So we have Dr. Sumathi from the same institute and Dr. Saityan, please. We start with Dr. Netherland, a keynote address on OCT in glaucoma.
No. What's in? Yeah. Perfect. Great. Thank you. So yes, welcome to this session. I think it's a very well-conceived session. I like the idea, and we're really trying to get at what are some of the major advances, in glaucoma. And in my opinion, certainly this qualifies as one of them, OCT. So nerve imaging, we've really been driven to because interpretation subjectively of photographs, drawings, and so forth is inherently imprecise and variable. So now we have OCT analyzers that do provide quantitative measurements. Yes, they're compatible with EMR, which is nice, but the main thing is that they're much more quantitative and they provide harder, more solid information for us as compared with subjective evaluations. Certainly the assessment of these scans has enhanced the diagnosis of glaucoma and also glaucoma progression over time, and I'll try to show you some evidence for that to back up these statements. So first of all, in terms of diagnosis, certainly the diagnostic accuracy of OCT is better than other imaging methods that have been developed, GDX, HRT, other ones. There's no question that OCT has inherently better resolution and is winning the race for best technology. It's pretty much now established itself as the leading technology for glaucoma imaging. So we can move beyond that and now really look at how does it perform. So it turns out that in terms of glaucoma diagnosis, it really only has moderate sensitivity and specificity for detection of glaucoma. There's been a lot of studies on this, and I'll just sort of summarize them to say that it does provide very useful information when you're initially evaluating a patient. But, can you rely upon this as a standalone test for glaucoma? Well, maybe not. You'll have some patients that have nerve fiber layer defects that are long-standing and due to other causes besides glaucoma, so it's not 100%. I mean, it's not very specific information necessarily. But it can be very helpful information that we use even for diagnosis of glaucoma in conjunction with the other assessments that we do, let's say intraocular pressure and visual fields. In combination with OCT can be very helpful for diagnosis. And it is certainly very accurate for identifying healthy nerves and large discs. So in this sense, it's fairly useful because there are many patients who are suspicious for glaucoma for a variety of reasons, and if they have a truly normal nerve fiber layer, that's helpful in identifying healthy nerve tissue. And I'll be showing examples of this as we go along, but really the more important application for it has been progression detection, and that seems to be its strength. So in terms of progression, it's quite useful to know if there's no change clinically. So you can have patients that you're following who are glaucoma suspects, and you may see some minor variation of the intraocular pressure or some other thing that you're following. But if you see this type of pattern that I'm showing here up above here on the left, really steady progression analysis curves, straight lines, no downturn, same exact pattern for a long time, you know, you're not seeing progression. And it's very useful sometimes to have that information to know that somebody really is stable. Glaucoma patient. Here's a glaucoma patient that, you know, does have nerve fiber layer defects and does have actual glaucoma, but their nerve fiber layer is staying, you know, fairly stable. There's no decrease over time. And on the other hand, if you have a patient like this, it's quite useful in picking this up. It's very sensitive for picking up small changes. Here you're seeing a patient that's developing a nerve fiber layer defect inferiorly here, and you're also seeing that in the curves where they're dropping down. You can see more dramatic drops for sure, but this is just one example from, I think I took them from last week's clinics. So it's very common to see that, and when you do see that, it really alerts you to the progression. So it's extremely useful for that, and these changes often precede functional loss, so they can be very sensitive. And certainly if you have faster changes, this is a bad situation because this has been linked in with more visual field loss. And it does appear that OCT is more sensitive than visual field now for progression detection, especially when you have early glaucoma patients. So it is extremely useful for that. Now, the concept has, of course, come up that, you know, maybe we should combine these OCT structural changes with functional measurements, and then combined together, these will provide powerful evidence for progression and essentially 100% detection. Well, that's definitely happening at this time. Right now, we do it clinically. We try to combine the information, obviously, separately, but there are some algorithms and some new tools that are being developed as we speak to combine this information, and they will provide very accurate information about progression in the future. So this is definitely coming and is already developed and being tested, and we will certainly see this in the future. But for right now, we do use them separately. Fact is that OCT does contribute greatly to this process. We have a lot of good machines now. The key thing has been that the resolution has increased over time. We had, you know, earlier machines, earlier generations of machines. Unfortunately, the data doesn't, you know, carry over from machine to machine. So every time there's new hardware, we have to get a whole new database. But it is an improvement. We use it because it's better. The resolution has increased greatly. We're now down to 5 microns with the Cirrus OCT, but that's already been improved greatly. And we're now seeing machines that are in development that are, you know, 1 to 2 microns in resolution, which will be really spectacular when we have that. So the machines are getting better and better all the time, and that's providing more and more powerful information for us to use. How do we interpret these things? I'm going to give you a few practical hints. We do have, the way I look at them is I look at a few things on the scans. We use the spectralis a lot, but we have the Cirrus as well. We have all of them actually, and multiple machines of all of them. But anyway, we have a normative database. It's important to use that to compare the information you have about the patient to what's normal. We have quadrant analysis and also sectorial analysis. We pretty much only use the quadrant analysis because the sectorial analysis has relatively small number of scans, and you know, it's not inherently quite as reliable. But green means it's normal. Yellow is in the lower 5% of normal. Red is in the bottom 1%. And white is in the top 5% or higher of normative database. So this is useful information. If you see red, that's bad, you know, and it's abnormal. So it makes it simple for us. We always use the average RNFL analysis, which is printed on the Cirrus in these little boxes up here somewhere, the average. In the spectralis, it's in the center display of the quadrant analysis. And the average number we always record for every patient, because if that shifts greater than 4 or 5 microns, you know that there's something significant going on as well. The disc area I oftentimes look at, that's one of these little numbers here in these boxes. Greater than 2.0 disc area is abnormal, and this is very helpful for identifying patients that have large discs. It's a congenital anomaly. It's very common, and if you see a patient that has large cups, but they have large discs as well, and the nerve fiber layer analysis is normal, that's essentially a normal person. But they may have very large cups, so it's quite useful to have the OCT information to see that. So in terms of what we accept for minimums, you got to have a reliable scan to compare them. So for the Cirrus, the cutoff is, they're different for each machine. So the Cirrus has to be greater than 6. Spectralis greater than 20, greater than or equal to 20. Rediview, it's greater than or equal to 30. Here's the Cirrus. You see it has to be, these are a couple unreliable scans. You have to have greater than or equal to 6. And then this one is also, I think this one is unreliable, this one isn't. But this is just barely reliable. But you can see, you start seeing nerve fiber layer analyses that are not really very reliable if you get these, quality of the scan is very low. So you have to get a good quality scan. There are several other artifacts to look out for. Medial opacity is a very important one. That can be due to many things: cataracts, corneal disease, pupils may be too small. It can be, it can capture an image through a very small pupil, but it can be too small. And then thinning artifacts, and image non-capture, maybe due to image non-capture as well. So movement artifacts, something really important to look out for: blinking eye movements, nystagmus, and that's manifested here. You see when you see these dark areas on the cirrus, this is better, but this is a lot of movement artifact, and that shows up as having a lot of red areas. This is the same patient that just didn't move as much, and so you've got a good quality capture there, and these are more reliable measurements than these over here. So then you've got algorithm segmentation failures, which the algorithms smooth areas. So you can have an actual nerve fiber layer defect. This is a patient that has a nerve fiber layer defect and a visual field defect, and yet their nerve fiber layer analysis doesn't pick up the RNFL defect. But there is actually one there. It's right here and here. So what it does is the algorithm, if you get to small areas of nerve fiber layer, will smooth those over, and so you can have what we call green disease. That means you're picking up something that's green, but it's not really normal in the real life. It's actually got a small defect. So you can have various artifacts. You have to look out for them. And they're important to kind of look out for. If you get a certain degree of RNFL dropout, you can have essentially so much dropout that you can't really detect any further change. This is really at the bottom of the scale. This is a patient that had really advanced loss. But if you get to this point, it's hard to pick up change also because it's at the bottom of the measurement, really. There's various other non-glaucoma abnormalities that you will run into. You can have the incorrect scan distance, high myopia, peripapillary atrophy, various other things that will cause abnormalities related to the patient, related to the scanning operator, rather. The patient may have various abnormalities that may cause things that are not normal, but it's not glaucoma. This is peripapillary atrophy causing a little bit of red areas here, but those are not because of glaucoma. And here's a patient with myopia, again, some red areas, but not because of glaucoma. So, this is why the glaucoma diagnosis, we have to get these baseline scans, then we can follow progression very accurately in these patients. Now, the impact of this has been huge, absolutely huge in clinical practice. Clinicians in the USA now use OCT for glaucoma evaluation and detection. In India, now, according to this paper in 2017, last year, we're a couple months out of date, but 3/4 of glaucoma subspecialists use OCT, and 83% use visual field. So here in India, I keep getting accused of bringing in USA technology and stuff that's not relevant. Here in India, it's relevant. You can use OCT. It's being used now, and it's highly helpful for using OCT. OCT has been a top advancement in glaucoma during the last decade, and I would say that with no doubt. We're talking about advancements. So in conclusion, OCT has an important role in glaucoma evaluation and progression in monitoring for progression. Assessment and clinical interpretation of OCT scans is a judicious process. You have to be careful as you look at them. You have to be able to be aware of artifacts. They can occur, and they can confuse your interpretation if you're not aware of them. You're looking for things that cause false positives. You might say red disease, or false negatives, green disease. But ultimately, we do interpret these scans in context of other clinical observations for sure. But we're finding really direct use for these scans now these days. And so again, I would assert that it has indeed been a very top 5 type of advancement that we've seen in the last 5 years. Thank you very much.
Thank you, sir, for that very informative talk on OCT. Next, is there any question you want to ask, Dr. Netherland? No. So we move on to the next topic. That's
in a role of OCT in what? I missed the last part.
Advanced cases.
Yeah, advanced disease. So certainly there's some literature that suggests recent papers. It's been a mixed bag on that. Yes, early disease. Certainly, most papers will argue that it's more useful in earlier disease because clearly you've got a lot more room to pick up change and so forth. Advanced disease is a little bit controversial. There are some people that look at that and say, well, the scan is already very low, you've got very little, before you can't detect anymore. But the recent papers have focused on the areas that you can see, and patient may have advanced disease, and there is, many authors are arguing that there is utility in advanced disease. You just have to look at the scan and see where it is dropping. It may not be average further decrease, but you look at the scan, you can see areas that are decreasing. And moreover, they're arguing that as we get higher and higher resolution scans, of course, you can go all the way to 0. And then you will pick up some, a person has some nerve fiber and you'll be able to pick up the change. So as the resolution increases, certainly we'll be able to use it much more for advanced disease. Right now, the problem is that you've still got a 5 micron, resolution problem. And so your issue there is that you get down to a certain point and you can't distinguish from 0. So that will improve, number one. Number two, if you look at focal areas of the scan, many authors are arguing that we should be able to use that for advanced disease. But yes, early disease better.
Sometimes we see that the patient has probably glaucoma with the visual fields, the IOP, and the optic nerve head findings. But when we do the GCC, it comes as normal.
Yeah. Yeah, that's a tricky one. I'm not sure. First of all, I think we have to say that yes, it can occur. It's unusual though, right? I mean, it's a small percent. But it can occur, and I don't have a good explanation for that. I wish I did. But I will say that, again, the strength of it is the progression analysis, right? So if you start picking up changes, then you know the person's baseline. We've had some patients that have had small discs and crowded discs, maybe nanothalmus or something. They have high pressures. They have some visual field changes, but they don't have, they're still in the normal range in the database. So I think the value there comes in the progression. Then you're looking for how is that going to change. You scratch your head and you say, I'm not sure how that makes sense in the diagnosis. You recognize that it's a small percent. It probably is due to something like that, small disc, crowded nerve fiber layer, but we don't know why. But then you can use it for progression.
You do use macular GCC for all.
Yeah, macular OCT is a very controversial one. I use it a little bit, especially for asymmetric disease. Like again, I just am a clinical user of OCT, and I think mainly for me, if I see asymmetric disease, I'll get a macula scan and I'll maybe try to follow that too. But for me, I just want to look at one thing, and I use the RNFL still. But I do find that to be useful in a small percentage of patients, sometimes out of interest, but sometimes clinically, if there's a big difference, you can pick it up in that patient.
Because there are articles now coming which tend to say that GCC is more reliable than the
Yeah, definitely. And then they're also saying things like the OCT angiography and things. And I think all those things, we're going to have to see. You'll hear advocates saying, oh yeah, I think angiography is the best or macular OCT is the best. Well, yeah, it's more direct measurement of what's being damaged, for sure. But again, with a 5 micron resolution, the issue that I've had with it is that it's not as perfect for picking up. But as the machines get better, certainly you can see individual cells and stuff. Well, yeah, then we'll have it. But right now, I think we're still using it as additional information, but not relying upon macular OCT, at least for the average user. So yeah, thank you.
Thank you, sir. And could you join us at the dais, please? So the first speaker of the course is Dr. Devendra Sood. He's going to talk on the new perimeter.
Thank you, Dr. Chandrama. And so, these are newer advances in perimetry. Even I'm not familiar with all of them. I've just tried to collate them together. But there are some bits and pieces that I use, and I'd like to enumerate about that in particular. For many years now, standard automated perimetry, that's white-on-white perimetry, has become the gold standard for the tests that we do. We usually, if you're a Humphrey user, you'll prefer a 30 or a 24-2 with a CETA standard strategy. If you're an Octopus user, you could use the G1 or the 30 program, and you would prefer either the top or the dynamic strategy. So advances have focused on trying to get more efficacious and make sure that your recordings are accurate, so that you can detect earlier the damage to the, you can detect functional damage earlier. Now contrast this, that many people in this room were brought up on perhaps a Jerem screen, Goldman perimetry, and then had migrated to Humphrey perimetry, where the strategy used was threshold. And then the CETA strategies came up, and that was an advancement because it helped save time. At that time, the traditionalists said that threshold is better because of the bracketing strategy, you are able to assess the retinal sensitivity at each point better, and that the theta is basically a supra-threshold. It's a compromise to save time. So the idea is, ideally, we need to look at perimetry. We should be able to screen populations. We should be able to reduce the testing time, and we should be able to test specific locations more energetically. So we have visual field apps which are available. iTune has one, and they can be used for self-monitoring. I talked about the strategies. There's a threshold strategy. There's a theta strategy which came in, and I now am given to believe that there's a theta faster strategy which has come in, which takes still more or less time. So there are lots of types of ganglion cells. Progressive damage to the ganglion cells eventually goes on to manifest as a functional field loss. Can we target specific ganglion cells so that the disease can be picked up earlier? So we're looking at the magnocellular, the parvocellular, and the coniocellular variety of the retinal ganglion cells. Shortwave automated perimetry, that's the blue on yellow test. It came in with a lot of fanfare earlier. It was placed on the Humphrey on the threshold strategy. It took about 25 minutes to do. Patients, once got it done, never wanted to go back to it. Perhaps a good test if you would target patients with ocular hypertension, apparently normal disc, and you were looking for some changes. The problem was that the test took too much time. Patients would actually fall asleep. Octopus, at that point of time, came out with the blue on yellow using the faster top strategy. So that's when it became more patient-friendly. Eventually, Humphrey also introduced it on the theta strategy. So the advantage of the blue on yellow test was that it was supposed to detect damage 3 to 5 years before it manifested on conventional white-on-white perimetry. Coming up on the faster strategy, it saved time. Then we had the frequency doubling perimetry, which focused on the magnocellular cells and determined contrast sensitivity using the doubling frequency stimulus. Again, the idea was to use it as a tool to assess early changes. And once you detected a change, you could go on to your standard 24-2 or a 30-2 pattern on the standard white-on-white perimetry. Then there is high-pass resolution perimetry, focuses on the parvocellular cells, using high spatial and low temporal frequency stimulus. Kinetic perimetry is what I've been using for the last 3 years for all patients with advanced glaucoma. We find it very effective in being able to at this point we've been forming a baseline, and we find that patients have received it quite well as compared to the standard white-on-white perimetry that we have been doing. We've done about 135 cases now, and we are trying to develop our own algorithm for the stimulus size and speed so that we can now introduce it as a part of our routine testing for all our glaucoma patients and not focusing just on patients with advanced glaucomas. Then we have flicker perimetry, which is looking at intermittent flashing stimulus on a uniform background. The advantage is that the cataract does not affect it significantly, and it's focused on the magnocellular pathway. Then there's motion perimetry, which is focused on the magnocellular pathway. It's another way of trying to pick up early changes in glaucoma. There's rare bit perimetry. The focus eventually is to be able to detect changes before conventional perimetry is able to pick it up. A lot of focus in perimetry has been on developing algorithms to assess progression. So the Humphrey looks at the visual field index. The Octopus looks at the trend analysis, but sometimes trends can show a stable change. But if you look at an event-based analysis, you could find that there is a change. If you look at a cluster analysis, or a corrected cluster analysis, you can find that even though the loss variance and the local defect tend to be stable, there is a change which is statistically significant happening in these quadrants. So in patients with advanced glaucoma, the trend analysis may be stable, but when you do an event-based analysis, you find that there is a change. So this is very significant for us to keep in mind. So newer advances in perimetry are something that we all want. We want them to perhaps replace our standard white-on-white perimetry as of today, but it's still going to take time. It's going to require studies over a period of time. Until that time, white-on-white perimetry stays the gold standard. Thank you very much.
Thank you, Devan, for the wonderful talk on the perimetry, newer perimetry. Actually, myself and of course Devan, the one who really inspired me to use the octopus. So we have a lot of interesting things in the octopus perimetry. Because I don't use Humphreys, I don't know how much of the advances had happened. So we'll have the discussion, a lot of discussion on that. So may I request Dr. Chandrima to talk to us on the new routes to target the therapy for precision drugs.
Thank you. So new routes to target therapy with precision drugs. I have no financial interest to disclose here. And right at the outset, I'd like to say that all these routes are in preclinical stages at present, but show us a glimpse of what is possible in the very near future. So polypharmacy. Patient adherence to glaucoma medication is a constant challenge, as you all know, and is recognized as an essential part of treatment. Contributing factors for poor compliance include difficulty of self-administering, forgetting to administer eye drops, inconvenience of frequent dosing, and unpleasant side effects. So these are the various routes by which we actually can administer glaucoma drugs, and I think only a couple of routes are explored. The others are completely left unexplored, and which are on the way. In this, the challenges of implantable delivery are many, but the most common challenge is with periocular administration. So the ocular delivery systems can be divided into conventional, vesicular, controlled release, particulate, and advanced. Ocusert is an insoluble insert and was first sustained release therapy, but it was discontinued due to certain disadvantages. We have bimetoprost periocular ring, silicon ocular insert that continuously releases. That's the ring on your left-hand side, which has continuously releasing bimetoprost, currently in phase 2 clinical trials, and decreases IOP to say about 18.8 millimeter of mercury at 6 months, and the ring is positioned under the upper and lower eyelids. That's how it is positioned, either upper or lower eyelids, and this is how it looks at the end stage. Intracanalicular punctal plug, hydrogel intracanalicular punctal plugs from Ocular Therapeutics, delivers travoprost for 2 to 3 months, which reabsorbs and drains through the nasolacrimal system. In a phase 2 clinical trial of the depot, sustained release travoprost showed clinically significant reductions in morning IOP. The Evolute or punctal drug delivery system. So the Evolute or punctal drug delivery system from Mati Therapeutics has been tested using latanoprost in patients diagnosed with open-angle glaucoma or ocular hypertension. The Evolute score drug allows unidirectional sustained drug elution into the tear film, thereby minimizing systemic absorption. So far, multiple multicentric US clinical trials indicate that lower punctum has retention rates up to 96% over a 12-week period. Then we have mini tablets, as you see out there in the picture, are biodegradable solid drug forms that transit into gels after application to conjunctival sac. This extends the time period of contact, which in turn increases the active ingredients bioavailability. Timolol has been used in this form. And then we have the contact lenses coated with drugs, currently in preclinical stages as replaceable drug delivery devices, nanodiamond nanogels that can be incorporated into a polyhema matrix and cast into contact lenses. Then you have the cyclodextrins, cyclic oligosaccharides, which form complexes with hydrophobic drugs, influencing their stability, availability, solubility, and tolerance. Without changing their molecular structure as carriers, they help to keep hydrophobic drugs in solution and transport them to biomembrane surfaces. In ophthalmic drugs, optimal bioavailability of the active ingredient is obtained at the appropriate concentration in aqueous eye drop solutions. The most commonly used cyclodextrin in the eye is 2-hydroxypropyl cyclodextrin, which does not cause irritation. As you see in the picture out there, you have the cyclodextrin hydrophobic group and you have the hydrophilic group with positive and negative charges, and complexes like pilocarpine with 2-hydroxypropyl cyclodextrin are well tolerated and ensure increased bioavailability in comparison to conventional ones. Then we have latanoprost. It's practically insoluble, as we all know. challenging to be formulated as an eye drop due to its poor water solubility. So propylamino beta CD has the best trade-off between latanoprost stability and availability. In vivo experiments demonstrated that this formulation led to lower ocular irritation than the commercial latanoprost. This combination formulation was also demonstrated to successfully address the main stability, solubility, and tolerance limitations of topical ocular latanoprost therapy for glaucoma. And this is how it works. So both of them actually decrease IOP equally, but the toleration is much better. The irritation is much less in this form than in the other form which is being used. So soluble ophthalmic drug inserts, they are called SODI, enhance patient compliance and ocular drug delivery in long-term glaucoma therapy in a small oval wafer developed by Soviet scientists for cosmonauts who could use eye drops in weightless conditions. This is interesting. In contact with the eye, the SODI softens in 10 to 15 seconds. The tear film turns into a viscous polymer mass in 10 to 15 minutes and then turns into a polymer within 1 hour while releasing the drug for about 24 hours. A single SODI application replaces 4 to 12 eye drops or 3 to 6 applications of ointments. So the active ingredient employed in research on SODI includes pilocarpine. So subconjunctival injections, administration of IOP lowering agents with sustained release for 3 to 4 months is another attractive alternative to daily eye drops. So this the time frame is about 3 to 4 months of delivery is constant with the frequency of routine glaucoma visits, and subconjunctival hyaluronidase injections lower the outflow resistance by up to 34% in normal eyes on an average and by up to 57% in glaucomatous eyes. Latanoprost loaded egg PC liposomes. So slow and sustained release of 60% of latanoprost was achieved by 14 days in the in vitro release study. The same formulation demonstrated a higher sustained IOP lowering effect compared with the daily administration of topical latanoprost beyond 90 days, and the egg PC liposome is injected subconjunctivally to raise a bleb as you see out there. So this actually has been discontinued, anacortave acetate. And then we move on to intracameral biodegradable nanotechnology polymer drug delivery system using the particle replication in non-wetting templates technology. Extended release of travoprost in the anterior chamber available in high doses. That's how it looks. And then we have the extended release of biodegradable travoprost also in this form, easily administered by a doctor in a simple office procedure. And it causes less hyperemia than the drops and fully biodegradable and excellent safety profile. Bimatoprost sustained release. It's an intracameral implant that resides in the anterior chamber, eluting bimatoprost in a sustained manner, evenly over 6-month period. And 4 months after implantation, IOP was lowered in 92% of patients, and this reduction was sustained to 6 months in about 71% of patients. That's how it is done. As you see out there, that's a picture of the anterior chamber. That's how a slit lamp photograph through a gonioscopic lens showing an intracameral bimatoprost implanted adjacent to the trabecular meshwork. Then you have the iDose glucose is a titanium implant that is comparable in size to the company's iStent, which was used in MIGS. So the iDose is filled with a formulation of travoprost and tapped into a membrane designed to allow continuous controlled drug elution into the anterior chamber. Once depleted, can be removed and replaced again in the subsequent procedure. And it's in phase 2 clinical trial as well. And the device achieved an approximate 30% reduction in mean IOP compared to the baseline IOP. Then we have the intravitreal brimonidine implant, so shown to have protective effects on retinal ganglion cell bodies as well, and currently being tested for the safety and effectiveness of a brimonidine intravitreal implant in patients with glaucomatous optic neuropathy. This is also in phase 2 trial. And we have the newer ocular delivery devices, like we have the nano carriers, we have the nanoparticles. In nanoparticles, we have acetazolamide and pilocarpine again being tested. And this is actually a list of the implant, the material used, the drug loaded, and the duration of release. So you have a whole lot of implants that are on the way. So we really look forward to all of these. So sustained release drug formulation may be a part of the answer to the compliance problem of polypharmacy patients. Early studies have shown that better tolerability of these delivery modalities compared with topical drops, but side effects may be challenging. So the future seems to be very promising with exciting new glaucoma treatments in the horizon. Thank you.
Thank you, Dr. Chandrama. Our next speaker is Dr. Susan Jacob, and she's going to talk to us about the evolution of MIGS.
So as I said at the beginning, Dr. Susan is caught up in a medical emergency at home. Dr. Sumathi from the same institute would be speaking to her on this.
Good afternoon. Thank you for the opportunity, madam. Stab incision glaucoma surgery, or a 6, which is usually called as, is a minimally invasive glaucoma surgery described by Dr. Susan Jacob. As we all know, that trabeculectomy is the gold standard treatment for the glaucoma, but over years several modifications have been done in this procedure to make the surgery much more simpler, to get a better filtration and with less complications. Stab incision glaucoma surgery, we use a 2.8 developed keratome, which is used to make a single stab conjunctival and a corneoscleral tunnel, and intentionally the posterior corneal lip has been compromised to get a filtration, that is posteriorly directed filtration. Let us go through the surgical video. This is a primary open angle glaucoma patient. The surgery was performed under periperipheral anesthesia. The first step is you mobilize the conjunctiva. This is very important. See, you can use either a rod or a non-tooth forceps. You can mobilize the conjunctiva and pull the conjunctiva over the limbus. If you feel that there is a amount of conjunctiva is less, maybe you can release your speculum and then do the same procedure, because you can many a times you can see the conjunctiva is stuck in the speculum too. And then 2.8 millimeter keratome is used to make a single stab incision from the 2.5 millimeter from the limbus. And once you make a stab incision in the conjunctiva and the sclera, you can actually scroll the conjunctiva back on the keratome, and the appropriate depth would be that the blade is just visible on through the conjunctiva. Once you reach the limbus, you can go ahead again into the cornea, 1 millimeter into the cornea, and then direct the keratome into the anterior chamber, so you make an entry into the anterior chamber. You can hold in the opposite limbus and slowly take the keratome out, and then you can see there is a inner corneal tunnel as well as a scleral tunnel. You form the anterior chamber by injecting viscoelastic. Either you can use the same tunnel, or you can make another side port and use the other side port for the injection of viscoelastic and washing. 1 mm Kelly sponge is being used to compromise the posterior lip, and the direction of your punch should be down and backwards towards your limbus, and after you one punch, you can make another punch till you reach the limbus. Sometimes maybe the scleral tunnel may not be visible. You can, at that time, you can just lift the conjunctiva and then see the tunnel, and then with a sideward movement you can get your Kelly sponge into the tunnel. You can see the internal lip over there, which is compromised, and then viscoelastic is being washed out. And through a side port incision, you can check the flow of the saline through the tunnel. Once you are injecting, you can see there is a free flow of fluid. If you feel that the flow is not adequate, you can actually go ahead and take an additional punch with a Kelly sponge. And once this is done, you can suture the conjunctiva. You can see the incision which is made in the conjunctiva is very small, around 2.8 millimeter only, and this conjunctival incision is far away from your scleral incision. And then the small incision has been closed by continuous suture using a 10-0 nylon. And then the anterior chamber is being formed with a saline. You can see there is a ballooning of the conjunctiva, and there is no conjunctival dissection being done. The ballooning is by the hydrostatic pressure of the fluid which is injected into the anterior chamber. Once this is done, you can close the case, And this is a post-op day 1 picture of the same patient. You can see there is not much inflammation in the anterior chamber. Eye is very quiet, and this is slit view showing the internal lip which is compromised and the diffuse bleb superiorly which is being formed. The bleb which is formed usually will be a flat, and the direction of the flow will be much more posterior. And this is the AIOC scanning, real-time scanning of the same patient. You can see the compromised corneal tunnel, and the same with the entering towards the subconjunctival space too. And the AIOC picture and the post-operative clinical picture of the same patient. And in certain cases where you can have a premature corneal entry, that is, this can happen when you don't have an 1 millimeter advancement into the cornea and you accidentally enter at the limbus. Don't worry, don't panic. You can always convert the case into conventional trabeculectomy. All you have to do is extend your conjunctival incision, and then the scleral flap which we have made here has been cut on either side, and go ahead as a conventional trabeculectomy surgery. I would like just to share a few study which we did on 20 patients who underwent this procedure. The inclusion criteria was primary open angle glaucoma, chronic angle closure glaucoma patients, and patient requiring glaucoma filtering surgery with or without phacoemulsification. Exclusion criteria was previously trap surgery patients or refractory glaucomas. And most of the patients were between the age group of 50 to 80, and male to female ratio was 1:1, and 85% of the patients were of primary open angle glaucoma patients, and in 60% of the cases we did combined surgery, that is 6 with phaco, and in only 15% of the patients we did PI. As such, complications in one patient we had an premature entry which we converted into a conventional trabeculectomy, and in the post-operatively we had small little hyphema or DMD and steroid responder which we managed medically. And in all the groups there was significant control of intraocular pressures when compared to the pre-op, and we had a mean follow-up of 28 to 29 months, and we saw that mean reduction in the IOP was much more in the patients who underwent directly 6 when compared to patients who were already on anti-glaucoma medications. As I said, like 6 surgery is gives a single small 2.8 mm cut in the conjunctiva, which is well away from the scleral cut, and there is not much of conjunctival dissection, and thereby you reduce the post-operatively the bleb scarring or risk for failure is less, and we get a posteriorly directed flow. And most of the cases we don't do a PI, and usually you can do a PI only in cases where you feel there is your tunnel is a very low lying, or it's shallow anterior chamber is there, or chronic angle closure glaucoma, or in case of PAS. The bleb which is formed here is hydrostatic and physiological expansion. The subconjunctival drainage channels are intact, and there are less flap related or suture related complications. And in case of premature entry, as I said, you can always convert into a conventional trabeculectomy. And 6 is a simple, effective, and minimally invasive glaucoma surgery giving good control of pressure. And most advantage which can I say is here is leaves the most large virgin conjunctiva. Even if you want to do another trabeculectomy, you can actually you have a good amount of conjunctiva which is left behind. And early results are promising, and long-term studies in terms of control of IOP and optic nerve damage is recommended, and comparative studies with conventional trabeculectomy and assessment of bleb morphology and drainage pathways is also to be done.
Thank you, Dr. Sumathi. We really appreciate sincerely your stepping in at the last moment for Dr. Susan. Thank you very much. We move on to our next speaker, Dr. Kirti Singh. OCT can help in diagnosing and treating progression. Dr. Kirti Singh heads the glaucoma service at the Guru Nanak Center of Maulana Azad Medical College, New Delhi.
Thank you, Dr. Chandrama, for having me as your co-instructor. So the topic given to me is OCT in glaucoma, both for strategies in diagnosing and treating progression. So please, let's go back to a few facts. The traditional tools for detecting glaucoma progression have been always subjective, whether they be visual field or they be optic nerve head. Visual field defect can be trend-based, visual field index, event-based, GPA. Optic nerve head exam, obviously it's structural endpoint. For OHTS and EMGT use these endpoints, but they're all subjective tests. Structural damage also precedes functional damage. So having based our thing on these two facts, we do extrapolate to early and moderate glaucoma and advanced glaucoma. Now the advanced imaging for glaucoma study, the AGIS 2017, Stratus OCT significantly increases detection rate for mild glaucoma versus visual field. In advanced glaucoma, now here the need to detect progression is critical because reserve almost is non-existent. And the tool, as we said, are very subjective visual field, which become even more unreliable because this poor retinal sensitivity makes it unreliable. Optic nerve disc, already if you have a 0.9 cupping, you don't have much reserve depth for the clock hours, how many clock hours are gone as per DDLS scale. So therefore, these tools are limited ability to detect disease progression. So in these scenarios, when 24-10-2 and macula are there, you're not going to help. If we have imaging tools like this to tell us whether there is progression, that will be wonderful. And we do have these tools available now, thanks to OCT. However, looking at this from evolution over the last decade, from time domain to spectral domain to the latest the block SWEPT, source OCT, where you have these parameters have been changing. The ophthalmologist needs to keep abreast of these technologies because they're evolving very rapidly. And as you can see from this very recent PubMed scanning screenshot, that so many studies have come up which talk about the OCT in glaucoma progression and diagnosis. So having established the relevance of OCT in detecting the glaucoma progression and for diagnosis, let's come to the what are the types. So currently time domain is out, it's spectral domain or the Fourier domain. Now in these the strategies are RNFL cube, which is 6 millimeter square, or the advanced segmentation algorithms have made macular GCC and GCIPL algorithms available, and retinal vessel tracking has made the interscan reproducibility much more. The latest kit is SWEPT source SSOT and SSOCT and the OCT angiography. The longer wavelength of 1310 nanometers makes it penetrate deeper, and the choroid is easily visible. So these are the strategies as they look. That is the macular cube strategy, and that is the optic disc strategy. Okay, so let's see how they work. Macular ganglion complex, as you know, retinal ganglion cell layer is three parts. Retinal nerve fiber layer is the axons of the ganglion cells. Ganglion cell layer is the ganglion cell body, and the inner plexiform layer is the dendrite. So this is measured by the ganglion cell or the GCC complex. When you remove the nerve fiber out of the equation, you measure the GCIPL. Okay, why macula? Because macular density of the retinal ganglion cell is maximum. It's 50% of the retina and it's multi-layered. Therefore, macular ganglion cell IPA complex thickness is less likely to reach the measured measurement flow level vis-a-vis circumpapillary RNFL thickness in advanced glaucoma. Therefore, it is a better tool for detecting progression. So that's the physiology behind this GCC and GCIPL. And this is how it is portrayed, okay, in 6-quadrant map: superior, inferior, supranasal, supratemporal, infratasal, intratemporal, global, and minimal unmeasured. And this is the MGIC-IPL or the macular ganglion cell inner plexiform layer, which is measured from here to here. And if you include the nerve fiber, it becomes the GCC. Please remember, there's a central masking area. For the residents to tell, the masking area is because the fovea has no ganglion cells. Okay. So this is how it is pictorially depicted. This is thickness map, the deviation map, and the significance map, where the thicker GCC are the warm colors and the thinner ones are the cool colors. Okay. Second one strategy is the optic disc cube. This again is 6 millimeter square area. Now information is extracted out of a 3.46 mm diameter circle around the optic disc. So you have to define termination of the Brooks membrane as the optic disc edge, and therein lies the problem. Now the new strategy in this is the minimum band distance or MBD, which has a software to get the shortest perpendicular distance to the ILM, which will define the optic nerve cup margin and the optic disc margin even better. Okay. The term which comes up is the CP RNFL, the circumpapillary RNFL thickness map. And here it is 4-quadrant, superior, inferior, nasal, temporal, or the Disnet map. And this is how it is depicted totally. For ease, new machines have come up with a combined printout of a macular GCC and the peripapillary RNFL together. Now that was the diagnosis. Now the progression. Progression pickup rate can be by RNFL change analysis, a longitudinal change, a reproducible change or decrease which you are expecting of more than 4 microns is significant. Now for having any change, you need a normative database. So please remember your normative database for all these fields, for all these machines is Caucasian, and they have come up with 1.5 micron reduction per decade as physiological. So beyond that becomes pathological. Second part is the guided progression analysis, the GPA, like the visual field, but this is guided. That one was glaucoma. So here you have a regression slope, line generated, longitudinal again, 4 to 5 visits are required. And you have 3 strategies: RNFL thickness mapping, thickness profiling, and the average RNFL, out of which RNFL thickness mapping is the most sensitive. First change is depicted as yellow, and confirmed on the second time is depicted as red. Inferior and infratemporal have been documented to be reduced more in progressors. And this is how the ganglion cell complex progression analysis, GCC progression analysis, is picked up, and that is supposed to be, has been proven to be more sensitive for detecting early damage vis-a-vis RNFL of the circumpapillary. Now, what is evidence? My children always ask me, what's the evidence to what you're saying? So evidence is the relevance to this OCT depicted changes? Yes, there is. The functional relevance, first of all, it was correlated with the National Eye Institute Visual Function Questionnaire 25 scores, and every 1 micron decrease of RNFL did give rise to reduce in the NEI5 score. Structural Functional Index. Now, these two interesting studies, the AGIS and the DIGS, Advanced Imaging for Glaucoma Study and the Diagnostic Innovation in Glaucoma Study, are attempting to answer these questions, and they've come up with some clues of GCC, GLV, and FLV, which predict future functional damage. So, and this is the structural progression which has been confirmed that rate of RNFL thinning is more in progressors. So OCT has validated its structure. In normotensin glaucoma, again, it has been proven that macular ganglion cell complex has an improved diagnostic ability vis-a-vis CPRNFL, which gives minimal defect, whereas MGCC falls down faster. The new kid on the block, as I was saying, is swept source OCT. Now that causes choroidal imaging to come up because it has a longer wavelength, which aids in overcoming lens opacities and has a deeper penetration. Resolution is around 1 micron, and it has a faster speed, over 10-fold faster, therefore motion artifacts are much less, wider field. Suprachoroidal space also is visible, and detailed lamella cribrosa depth index has been now documented on this, which will correlate with the bowing of the optic nerve head. An OCT angiography tool, again, is a non-invasive, rapid SANS diagnostic tool, high resolution, motion contrast strategies used, and they have proven that after trabeculectomy, that maximal reduction in IOPs happens with trabeculectomy, and the lamellar cribrosa index and the retinal microvascular improve after on OCT angiography. And the terms used are OD profusion, flow index, vessel density, phase area, and peripapillary vessel density. This tool is giving hemodynamic insights and psychophysiological measures, and this is how it is depicted. So the new strategies, in addition to OCT angio, are the enhanced depth imaging, where the cribriform plate deformation has been quantified as lamina cribrosa depth, or the LCD displacement, lamina cribrosa curvature index, or the LCCI. And the new adaptive technology has also come up with the nerve fiber bundle defects and gaps have been identified. Therefore, the margin between structure and function is been blurring because of the advances in OCT imaging. However, this tool also has Achilles heels. It's not hunky-dory. It has problems. First problem is disc morphology variation, and this is more in the CPRNFL because there is interpatient variability in disc size. Morphology makes the reference plane placement for RNFL measurement difficult, especially for large discs, tilting disc, peripapillary atrophy, situs inversus. How would you place that? And myopia. That's a very common condition, and the risk of glaucoma is 2 to 3 times in myopia. The disc clues are distorted, reference plane is distorted. Increased axial length would also make the RNFL thinner. Therefore, macular ganglion cell in a plexiform layer measures are preferred in myopia, and this DIG study, a longitudinal study, is being done by spectral OCT, angiography, and central visual field, and they are trying to devise database of healthy myopes and check out the advanced crisis of myopia and see how to use it in myopia. Other problems are in scan location, head positioning and eye positioning, motion artifacts, less with spectral domain and least with SSOCT, measurement errors, signal strength is important, only above 66, about 10 signal which to be taken. Poor signal will underestimate RNA field thickness, media opacity, ghost images because of vitreous traction, ethnicity, as I said, normative database is for Caucasians. And finally, you have to correlate clinically. Your OCT may be showing you progression, may be showing you an RNA field defect and an MGCC defect, but the patient may be a case of multiple sclerosis. So ultimately, these tools have enhanced our understanding, and it's like an open sesame. Things have opened out, the OCT has opened out the function, the structure, and as I said again, the structure and function boundaries are being blurred because of the new advancement in OCT. Thank you.
Thank you, Dr. Kirti. That was indeed very well covered. Could you please join us on the dais? And the next speaker is Dr. Sethan. Dr. Sethan is the director of the Sethan Eye Hospital and the Coimbatore Glaucoma Foundation. Welcome to the course here.
Thank you. Good evening to all of you here. And welcome to Coimbatore. Thank you, Dr. Chandrima, for giving me this opportunity to talk on the new phase of glaucoma drainage devices. I just asked her what is that I'm supposed to be talking about in the glaucoma drainage devices. She said you can talk about the AUDI device, which has already been there. So I think all of you must have heard the AUDI device so many times, but still I'll just touch upon a little bit on that. Just to go back to the history, it is 1906 where the earliest attempt was attempted with a silk thread, which is not been changed much. Instead of we use the silk, we are using silicone tubes, and it is been just attached with a plate now. So that is the only difference I can see from this 100 years plus. The GDDs can be classified into with no resistance and with the resistance where there is a valve. The Ahmad valve is the example, and we have the beveled and RD, which is most kind of similar ones. I'll just go through that. We have this RD device as well as the beveled, which was available. Now it is not available in India, which has been promoted by AMO earlier. So it is what I see in this is more problems in the sense the IOP reduction is much greater than the Ahmad valve, but only problem is the shallow of the chamber and other associated problems are also equally high with this GDD device. So that is the one thing. We have Maltino, which is not available in Indian market. So these are all the indications for the glaucoma drainage devices. But one thing which I wanted to tell you is on particularly this RD device or the beveled. Where I am not comfortable is the glaucoma in aphakia. So these patients we have to be very careful in using these non-valve devices where the IOP is going to be much lower and can have more complications when you are using this device in glaucoma in aphakia. Otherwise, the indications are almost the same for both valve as well as the non-valve devices. So both the beveled, when I was in US in 2003, we started the development of RD device, and then we had issues, and then it was started only in the year 2007, and then it was modified with little bit of changes from the actual beveled. Only change in the RD device is the barium impregnation in the silicon plate, which is not there with the RD device. Otherwise, it is almost the same. But the beveled device is available in different sizes. But the RD device is available only in 350 square. So this is the RD device. It is almost similar like beveled device, but the plate is much more flexible than the beveled plate. So that is the one ease which gives us when you're doing the surgery where you can push it comfortably underneath the muscles. That is one of the advantages of the RD device. So I just have a small video. It's not a very great video, but you can still understand. First of all, understanding the patient is important because you have to just make sure that the location where you really want to do the surgery, that is the primary importance when you are doing these drainage devices. If you just
touch a conjunctiva where there is already a lot of scar tissue, you will end up with more bleeding and more cumbersome procedure, and you may not be able to really close the conjunctiva back. So that is where your plate or the tube is exposed. Once the limbal area is exposed, it is a matter of time where the patient is going to have the infection. Especially those with younger patients, they develop infections very, very quick. So you have to be careful in selecting the place, see the conjunctiva where it is, the mobility is much better, and then first, for me, the most convenient place is the inferior temporal area, but you can always select the area which you are comfortable with. Some people select only the superior temporal. It is up to you to decide whichever area is comfortable. So the dissection is not like AGV where you can have a little smaller dissection, but it has to be a little wider, the conjunctival dissection, for you to hook the muscles, where in AGV you don't have to really hook the muscles. You can just go posteriorly and then push it. So that is much easier as a valve device. Then once you have done the conjunctival, this can be done under topical, but there is a lot of controversy on whether you can do it under topical or not. We are not going to the discussion now. We can have the discussion later. But it can definitely be done under topical anesthesia also. Nowadays I just do it only under topical. So this is the plate. Once you have seen the plate, what is, I'll just go a little back here. What is important here for you is, sorry, one step here. You just take the plate and then identify whether there is a small area of plastic is attached at the tip here, somewhere here. If you see that, make sure that you flush the tube nicely to make sure that the flow is proper. If you're not flushing it, sometimes that was the earlier ones we had the problems, but nowadays it is not there. But still it is better you flush the tube and see, make sure that it is patent or the flow is good there. Then you have to identify the rectus muscles. Some people used to use the same hooks of the squint hooks, muscle hooks, but if we are going to use a bigger muscle hooks, it is little difficult. So use little smaller muscle hooks for you to identify the muscles and then hook it. It is much more simpler. Then push the plate in. I'm sorry for the video is not focusing on the plate there, insertion, but just make sure that it is freely mobile. If the plate is not freely mobile under the muscle, that means you are not in the plane, or there is a lot of tenons or something which you have missed the plane. So make sure that it is in the plane. Otherwise, make sure that you go back and dissect, then you push the plate in. On either side of the muscle, underneath the muscle you have to push it. Once it is being pushed underneath the muscle, then the next step is the anchoring the plate. Again, there is a controversy. I don't anchor the plate either in AGV or in the OD, but some people are more comfortable in anchoring the plate. The idea of anchoring the plate is to make sure that there is no migration of the tube in the anterior chamber, either more anteriorly or posteriorly. Either one can happen, but I have not seen much, but over a period of time it might happen. So it is better if you can see comfortably, do anchor the plate, but it is not very easy to anchor the plate. But with the OD device, even if you just push it in, it goes in smoothly. The needle goes in smoothly in the plate, so you can easily anchor the plate. So once the anchoring is done, then just, this is the second time I am just trying to test. So after the ligature here, you have, as it is a non-valve device, you have to ligate the tube. We were using 8.0 earlier, now we use only 6.0 Prolian suture to make sure that it is really tight enough. There is a new development in this is we use the gelatin. We haven't started using it. We use the gelatin which is packed into the tube and which dissolves over 6 weeks time. So it is under the testing. I am not going to say which company is giving and all those things we are not supposed to reveal. So once it is there, then this ligature is probably not required, which is a little tricky. Once you tighten the 8.0, especially the 6.01, sometimes the tube gets cut. So you have to be a bit careful when you are tightening. Tightening one area is not enough. You may have to put 2 sutures so that it is really tight enough. So once it has been done, then the next thing is little bit of cautery here, because Once you see a lot of bleeding area, then it is difficult for you to proceed. So just cauterize, and next thing is putting the creating the tunnel. So earlier we were using like we make a small incision and we create a tunnel and then put the tube in. That is actually one way it is easier to push in the tube inside than just making a direct entry into the anterior chamber. Small cut here and then make a small tunnel. That is much easier to put the tube in than the just a straight away incision. And once you have done that, so this is the tube insertion. So the tube goes in much more easily. Once the tube is in, then you have to put the patch graft over the tube, and then closure of the conjunctiva. So this is the last one. Conjunctiva is closed tightly. To make sure that don't use any very old sutures. Some of us have the habit of using the ETO sutures. Make sure that you don't use the ETO sutures, because the conjunctiva in these cases will definitely retract. Why I am saying this is, I have seen many people using the ETO ones. So I thought some practical tips might help people here than just showing some videos. So thank you so much for hearing this.
Thank you very much.
We can have more discussion than because
yeah.
everybody has seen this many times.
Yeah, and I want Dr. Ramakrishnan to please come up to the front. Okay, we need your opinion. Dr. Ramakrishnan to please come up to the front. Yeah, so thank you, Dr. Satyan, for sharing your practical experience with us on the ADI. The ADI has actually been one of the revolutions in the glaucoma drainage system in the past decade, and Dr. Satyan has really been a part of it because he is the ex-head of the glaucoma services, and we have here with us Dr. Ramakrishnan. So we'd like you, sir, to share your opinion regarding the ADI, how well it has done in the past decade as a glaucoma drainage device, giving it a good competition. Does it give a good competition to the Amit glaucoma valve? Has it replaced it totally in your Amit glaucoma valve surgeries? Could we have a microphone for sir, please? Microphone. So you can hear it from the horse's mouth. Yeah.
Thank you, Chandrima. It's an easy question but difficult to answer. These drainage devices, we are using it for quite a long time. And of course, we are using Barwell's, AGV, and previously we used Martino too. But the main problem at that time was cost. That's one of the important restricting factor. And of course, now the RD implant, not only the cost, the ease of insertion is also another thing, because the plate, if you take, the plate is very much flexible, and easily you can just get into underneath the recti muscle. That's one thing. And also we seen the migration is not, we have not seen any migration, and also the silicon is also much more thinner and is not like the other one where we are not seeing any tube erosion so far in our practice. And of course, I don't think it's not a competition for other implant, but it's a good implant when compared to, not compared to, it's when you see it with other implants like Barwell's. But of course, it's the post-op results are so many studies have been done. Dr. Susmita has published a paper on pediatric glaucomas. The results are almost equal with the other implants. Yes.
That's wonderful, sir. Thank you for sharing your opinion. Could we have, yeah, please do ask.
Sir, can I ask a question, please? Because I haven't used RD at all, actually. But the thing is that because AGV does have a hypertensive bleb phase very frequently, almost 30 to 40%, or sometimes even 50%.
Yes, yeah.
Does RD also
have
definitely,
yes.
Definitely.
Yeah,
so it's a similar...
same thing.
Okay,
yes.
Thank you.
And do we have somebody, a non-Arvind, who's used the ADI? Dr. Mayuri, have you used the ADI? Is there anybody who else who has used the ADI apart from the Arvind group?
plate is so soft, so putting underneath the two extraocular muscles, sometimes it's very difficult. So for the first attempt, and we were not very encouraging in inserting that soft.
Actually speaking, it is very easy to put this.
Maybe for you, sir.
No. This silicon plate is very, very flexible, which goes in very comfortably than the bevel device as such.
The bevel, though, it's not available in India.
Not available. We have used bevel also earlier, but then it is very, very simple to push this in once you have really identified the muscle belly, and then there is a dissection has been done comfortable. I mean,
when
easily.
we see the movie, it is so simple. But I am used to AGV. And
but if you have somebody, the squint surgeon, you can tell them to just isolate the muscles. Isolate the muscles, then it is very, very easy. It is not that difficult for you to push in the plate in there.
Anybody else wants to ask anything else on the ADI or any other drainage device for that matter?
The barium impregnation was done earlier for identification by the X-rays.
Yeah.
So that can be easily identified where the plate is.
Yeah,
but then
that's important.
I don't think it is really.
You really need to identify.
No, that is not really.
Dr. Netherland, would you like to add something to it, please?
Well, I would just like to congratulate the whole group at Aravind for developing it. It's a great accomplishment. You know, it's going to make it practically available for patients, and that's a big that is a big advance. So I think we would anticipate similar results to Barvelt probably. I mean, I think it should be very similar. But the key thing is, as Dr. Ramakrishnan said, it's practical, you know, which is great. So I think it's a significant advance.
Thank you, sir. So is there any other question you'd like to ask any of the other speakers? Yes, please. Just okay.
See, basically, it's a feel that you have to have. Once you push the AGV in, and suddenly you feel that it has fallen into the pit. The moment you feel that, those kind of surgeries I don't really anchor. But if you feel that it is really stuck, it is not going more posteriorly, those patients I do the suturing of the plate. So I really don't know how to explain that more than that, but you have to feel that the moment you push it in, it just falls in. There is no more resistance for the plate to come out. So those kind of things. Second thing is in front of the plate, I make sure that the scleral patch graft is very well sutured, so that it kind of prevents the migration of the plate, and also we put that tube also.
There is actually we are the beginners and we are actually not getting the scleral patch graft. So is there any alternative so that we can manage the implantation of tube without the patch graft?
But I would still go with the patch graft. Even with the patch graft, we still have the exposure of the tubes. So it is better to go with the scleral patch graft. LVP, you would just send an inquiry to Dr. Sirisa or any of the department people. I think they are giving the scleral patch graft at some very nominal cost. You can have it. And you can keep the patch graft for a long duration of time. In 6 months, you can still have it with you.
Thank you.
But Vologen is little different because once it is wet, it kind of dissolves. So you have to be a bit careful when you're.
Sclera is actually a problem because there are new Orbo rules which have come in, and your theatre needs to be registered to be able to receive the scleral patch graft.
Yeah, keratoplasty we are doing regularly. The cornea
doing
people
keratoplasty, what is the problem?
No, but they are bringing the samples.
I think you should not be in.
No, I am not doing. The cornea people they are doing.
But the cornea people are doing, somebody else is doing. But when you have the eyeball, what is your problem? I don't think you should have a problem.
No, they are bringing from the eye bank, no. So we are not processing that one. So that's what. If we get the process.
See, it is a preserved sclera with the whole eyeball, right?
Yeah.
So what is the problem? You can use it definitely.
Oh, that one we can use. Right?
That is same thing. We are not getting sclera from anywhere else. It is from the eye bank sclera only.
And I can make a comment as well. It's a good question, and there's basically two alternative approaches. You know, first of all, you can make a longer scleral tunnel. There's many papers about that, and if you start the scleral tunnel more posteriorly with your needle and you can advance it, you can there are a number of papers published about this showing that you can not use a patch graft. Now, there's not a lot of, the reports don't show a lot of complications with that, so it's, perfectly acceptable to try, but you'll have to see what your clinical experience is. Second approach is you can also use alternative materials, and there have been many materials that have been developed. Currently we're using cornea, but that's an eye bank material as well. But you can use pericardium, that's another banked material as well. So you have all of the issues with autologous materials that come up with the same thing with the scleral patch graft. But you can use autologous materials as well, and that's been an age-old, that we've used for 30 years. If you have a patient that, you can even use fascia lata. You can harvest for zero cost from the same patient some material somewhere, and there's much literature about that as well. So you can find a no-cost alternative. First of all, try to convince them to get the scleral patch graft because it's just easier, it's better, in many ways. But if you have to, you can do a longer tunnel, and that is an acceptable technique. And you can also use autologous materials as well. Although, again, that takes some explanation of the patient as to why you're operating on their thigh and you're fixing their eye or something like that. So you have to do some explaining, but you can find other alternatives.
Actually, what we do is, did you have a problem with cornea, or is it just sclera only? So then what's the problem with cornea? If you have, like what we have been doing for the last, we don't do too many because of the restrictions to buy a tube shunt. We just take the corneas which are discarded, which are not, if they are not used for therapeutic keratoplasty, I just use a trephine of the cornea, of the discarded corneas, which are 1 month old or 2 months old or not fit for keratoplasty, and I just use that as a patch graft.
The cornea that can be used as a graft.
The thing with cornea is twofold. One is that you have to scrape off the epithelium of the cornea, otherwise the conch will retract from the cornea. Okay? So you have to scrape the epithelium, and you can design the cornea, and I find it's better. I've shifted from my patch graft to cornea because I can see the tube through and through. I can see where the tube is going. And second, what Dr. Peter was saying, that you have a long tunnel, but you have a long tunnel. Having said that, we started the AGV, we're doing the AGV 1997, and the technique we described was just like a trabeclectomy, partial scale thickness flap, and putting the tube beneath that. But I personally have witnessed a lot of a tube migration and tube erosion with that. So I don't propose that anymore. But if you have a relatively thick sclera, which is very rare, you can try that. But I would still advocate to add a patch graft. And if you don't have a scleral problem, use cornea. No issues on that.
Thank you.
Just scrape the epithelium off.
Use your.
Because we used to see earlier much more we have put in a long tunnel and things like that. But still we used to see the erosions.
I agree, and I'm just trying to address I know there's some issues with that, but I'm trying to address the issue of low cost. So there have been many places where there are the same issues. One of the earlier papers on long tunnels was from South Africa. They have a very high risk population, and they use long tunnels. And it can, I'm just saying, he's asking, is it low cost? You don't want to buy the scleral patch graft. So, cornea is a great idea. We use cornea because we can put on a restriction suture and then laser through it. We can visualize it, do a laser, and open the thing whenever we want. So it's great. We love cornea, and also you can see the tube, and there are many things that are positive about it. We like it. But I think if you're talking about something that doesn't cost any money, any additional money, then that's another question. And sometimes that's the situation. So I think if you're talking about harvesting from the body somewhere, you can do cartilage, you can do various things. But I think the best, probably one of the best options is like the technique you described. You can try it. You'll have probably a higher erosion rate, perhaps, but it may cause some issues. But you can try it. That's probably your best low or no cost alternative and I think that's really the essence of the question is what if you don't want to buy the patch graft? That's the essence of it.
Another thing what we do is we put the cornea in absolute alcohol for half an hour before using it, so it makes it more compact. Okay, so you just the cornea people have absolute alcohol all the time with them, so I just bought it from them, put it in, and I use that cornea.
Just to the panel, another low-cost alternative, getting back to sclera, is many times, some of the eyes are preserved by the eye bank that are in glycerin, and you can get the whole eye, and you have many patches from one eye from glycerin preserved. Is that an option here where you can get you get one glycerin?
Yeah. So that is an option as well. Yeah. So with that, we just have 2 minutes to spare, and if you don't have any other question, then no other questions to go, fine. So I thank my co-instructors and Dr. Netherland for making this a useful and fruitful session. Thank you very much. Thank you.